Hello everyone and welcome to our first live recording of Duchenne UK's DMD Care's webinar series. So I'm Alex Johnson and I'm the co-founder of Duchenne UK. We're also joined today by Emily Crossley. I also run the charity Joining Jack. So in my role, I'm constantly approached by families who express concerns and anxieties about the care that's being delivered to them and the differences between that care and what is published in the international standards of care. So what Duchenne UK has decided to do is launch a programme called DMD Care UK. This programme looks to bring together Duchenne experts in the UK with the Duchenne community to review the standards of care that have been agreed and published recommendations for every area of care that can and should be delivered within our healthcare system, the NHS. So today's webinar is focusing on the first group's recommendations. Today we're joined by experts from the Bone and Endocrine Working Group. I'm delighted to say we're joined by Dr. Jarod Wong, Dr. Claire Wood, and Dr. Talat Mushtaq and Vici Richardson, our patient representative. So now I'd like to hand over to Cathy Turner, who is the project manager for DMD Care UK.
Thank you, Alex. The DMD Care UK project was officially launched this month with a determination to improve care for all people living with Duchenne muscular dystrophy. Through a series of expert working groups drawn from the North Star Network and the patient community, we will establish UK recommendations based on the 2018 International Care Considerations published in the Lancet Neurology. We will work to seek the endorsement and implementation of these UK recommendations across the whole network so that every centre is able to provide the very best care for every patient. Now, the Bone and Endocrine Working Group is a step ahead. So they've been consulting and focusing hard under the excellent leadership of Dr. Jarod Wong over the past 18 months and have now released the first set of recommendations using this model. These will be published on our project website, along with information leaflets for patients and families at www.dmdcareuk.org. I'm going to hand over to the experts in just a moment to talk through the UK recommendations and to answer your questions at the end. But before I do, we felt it was important to highlight that these recommendations are based on the international standard of care. Where there are some differences, this is mainly to make them more feasible to implement within the UK healthcare system, or to clarify things which the group felt were not as clear as they could have been. For example, under Adrenal, the standard of care and the PJ Nikolov protocol mention the need for the consideration of oral steroid stress dosing during acute illness based on the dose of prednisolone or deflazacort prescribed. To simplify things for clinicians and patients, we have stated that all should have oral steroid stress dose during illness. Under Bone, the standard of care recommends spinal imaging every 1 to 2 years when on steroids and every 2 to 3 years if not on steroids. We made it simpler by recommending annual spine imaging for all. And under Puberty, the standard of care suggests examination for signs of puberty from age 9 years. But our consultation felt that the examination from the age of 12 would be more appropriate because testosterone for management of delayed puberty can be considered from the age of 12 years. So I'm delighted to now be able to hand over to the DMD Care UK Bone and Endocrine Working Group to present and discuss their care recommendations for the UK. And we'll start with Vici Richardson, who is the patient advisor on this group.
Hello, and thank you for inviting me. So my son has been on steroids since he was 5 years old. He's now 18, so it's 13 years of steroids. I think there's a lot of confusion within the Duchenne community about what to do with giving extra steroids and stress dosage. So we really welcome this working party and the standards of care that have been produced. Until recently, I myself was not aware that I should give extra steroids to Zach for anything other than an operation or if he was unable to keep a steroid dose down. So I think there's been some work to be done on raising the awareness of the issues, and the leaflets that have been co-produced are a really great start. I think when starting on steroids, an information pack would be really useful, and if this could be the same across the UK, that would be even better. I feel it would be useful for health reports on packs to be given along with training and for this to be revisited annually with patients. Currently, this isn't available at every clinic, and this causes a great deal of confusion within the DMD patient community. There's even different practice we've found within the same clinics. Steroid alert cards that can go along with the patient is also essential, and this is the feedback that I myself get from within the community. In regards to testosterone, my son was really fortunate in that he took part in the recent testosterone study. He started that when he was 15. I have to say the changes to his self-esteem have been amazing. He's happier, he looks older, and he loves that. He also grew a little taller, and he loves his facial hair. Sadly, he lost the ability to walk during the study, so his personal care needs increased just as same time as he was developing physically. We worked through that, and at the same time, we started to get some support from social care in terms of a PA. Before beginning testosterone treatment, I feel it's really important for clinicians and parents and the young people themselves to be really mindful that the changes could coincide with loss of ambulation and ensure that appropriate pathways for psychological support are there if necessary. Full conversations need to be had with the young person and the caregiver about the changes that will happen to ensure that everybody is prepared for that. And if the young person needs that extra support, there is time to sort that.
Thank you, Vicky. I think that really did summarise a lot of the concerns that the community express, you know, that we see, you know, written in forums and when people call us asking questions. So really a big thank you from me for sharing your perspective. So now we'd like to hand over to Dr. Talat Mushtaq, who's going to talk about adrenal insufficiency.
Thank you, everybody, and it's been a pleasure to be part of this project, and thank you for inviting me to talk. So I'm Talat Mushtaq. I'm a paediatric endocrinologist at Leeds Children's Hospital. And I think the most interesting thing I've got to say is that we've got a new hospital coming here in about 6 years, and it'll look really nice. Thank you. Next slide, please. So I'm going to talk about the adrenal glands, which control the body's salt and water and sugar balance. The adrenal glands sit just above the kidneys, and they make mineralocorticoids, which control salt and water, and cortisol, which control the blood sugar. And together they control blood sugar, blood pressure, energy, and they're an important stress response for fighting illnesses or if you've had a fracture. Next slide, please. High-dose steroids have got lots of really important medical effects. So they reduce inflammation, they're used to suppress the immune system, and they're used to treat really lots of medical conditions, from asthma to leukemia to arthritis, and of course to Duchenne muscular dystrophy. They come in sort of a number of formulations which have different potencies, strengths, and half-lives. For example, we have prednisolone, deflazacort, and hydrocortisone, to name but a few. But the downside is that if someone is on long-term steroids, so we may say generally about a month, if they're on long-term high-dose steroids, it can actually stop the body producing its own hormones from the adrenal glands. So essentially the body slows and shuts down, and if you suddenly stop steroids, then there's a danger that the body may not be able to compensate during times of illness or need. Next, please. So that then leads on to adrenal insufficiency, where the glands just can't make enough of their own steroid hormones. And that's especially important when they're unwell. Signs of that may include being weak, sort of lethargic, looking a bit pale. They might be quiet or grumpy. They may have diarrhea and vomiting because they're so unwell. At times they can have lingering illnesses. And in some children and adults, it can lead to collapse and coma. The treatment is straightforward with regular steroid medication, giving extra steroids when they're unwell. Otherwise, it can lead on to an adrenal crisis, which is life-threatening. Next, please. So in essence, when individuals with adrenal insufficiency are unwell, they need to have steroid stress dosing. And there's many different sort of recipes out there, but in relation to DMD, and after consulting with a number of pediatric endocrinologists around the UK, we decided it would be best to divide them into to either give steroid stress dosing with hydrocortisone, which is given 4 times a day, or with prednisolone given twice a day. But with prednisolone, there might be a need to split the dose and give it twice a day if they're already on a high dose of steroids. So in essence, if we imagine the average boy might be from 36 to 60 kilograms, in the region of 6 to 9 stones. If they were having hydrocortisone, they would have a dose of 7.5 milligrams 4 times a day. And if they were on prednisolone, they would have 5 milligrams twice a day. But if that individual was already on 20 milligrams daily prednisolone, we would recommend that boy just have 10 milligrams twice a day because they're already on such a high dose of prednisolone. Next, please. And either, oh, sorry, it jumped. So either hydrocortisone or prednisolone can be used for stress dosing. And in essence, if all boys can have hydrocortisone, and all boys on deflazacort can also have hydrocortisone. If the individual is on prednisolone, they can also all have hydrocortisone, or they can split the prednisolone. And now you'll notice that we've not given a schedule for deflazacort, and that's because there's not enough experience in the UK or published data to know how to use steroid stress dosing for those on prednisolone, for those on deflazacort. Thank you. Next, please. And the main thing is to avoid an adrenal crisis where the individual may be unresponsive. If they're having diarrhea and vomiting, they can't keep any of their medicines down. They might have low blood sugars, low blood pressure. They might have had a fracture. So in that case, you summon the emergency services. It's very useful to have an adrenal crisis bracelet, and the Duchenne UK have got some very nice ones just released. They should have additional emergency hydrocortisone at home, either for the parents to give or for the emergency services to give. And the dosage tends to be age-based, and the vast majority of our group will be over 6 years of age, and they would have the full 100 milligram vial injected into the muscle. Thank you. So the UK recommendations for assessment and management of adrenal insufficiency indicate that all boys with DMD on prednisolone or deflazacort should be presumed to have adrenal suppression, have an emergency steroid plan for acute illness, be educated about steroid doses, and use a medical alert. And if unsure what to do, if your child's unwell, it's safest to give more steroids and then think about it later. Thank you.
Thank you very much, Talat. I'd now like to hand over to Dr. Jarod Wong.
Thanks very much, everybody. So it's a pleasure working with all the people on the working group and also with Duchenne UK. And I'm going to talk to you over the next sort of 5 or 8 minutes to talk to you about bone monitoring in boys with Duchenne muscular dystrophy and what we've implemented as the UK standards of care. Next slide, please. So we know that as children grow, muscles develop, and children not just grow in size, but muscles develop, they grow bigger, they grow stronger. And as a result of that, bones also develop all throughout childhood. And this is largely through physical activity, particularly weight-bearing physical activity. We know that particularly with high impact physical activity during childhood, this leads to growth of the muscle, and it also causes little micro damage to the bones, which leads the bones to become thicker and bigger. This is partly also due to the fact that muscles secrete little nice chemicals which help the bones to grow stronger and bigger. But we also know that bones also make, muscles also make nice chemicals which help bones to grow thicker and vice versa. As children grow, we know that under the influence of hormones during growth and during puberty, bones also become thicker. And you will hear later from Dr. Claire Wood about the importance of addressing puberty in boys with Duchenne, as Vicky very nicely said earlier, about improving their self-esteem, but also improving bone health. Throughout childhood, we know that nutrition like calcium and vitamin D is also very important for improving bone strength. But we do know that in a boy with Duchenne muscular dystrophy, one of the biggest culprits on bone health is not just the underlying muscle condition, but also steroid therapy, which can have a direct negative impact on bones, on growth and puberty, and to some extent on absorption of vitamin D. And as a result, brittle bones or osteoporosis is very common in boys with DMD, particularly those who are on steroid therapy. Next slide, please. So in some work that we've done last year by Dr. Shuka Joseph, looking at fractures in boys with DMD managed in the Scottish Muscle Network, we found that at least 50% of boys with DMD will sustain at least one fracture and some multiple fractures. Most are in the long bone, particularly of the lower limb, which is different from the pattern of fractures in adolescent boys, for instance, which tends to be in the forearm. And about 30% of long bone fractures are fracture of the femur or fracture of the big bone in the thigh, which tends to be seen in older women with osteoporosis. 60% of long bone fractures are due to very minor falls. Most of our patients were just from falls from walking or from standing, in fact. And therefore, it's also important as we address bone health that we also address the muscle function and contractures, because if you imagine, if the boy is unsteady or there unequalness in the contractures in the lower limb, you're more likely to fall and therefore more likely to sustain a fracture, even with minor falls. About 25% of these long bone fractures are due to falls from wheelchair. And in an older adolescent boy or a young adult, it's very important to have wheelchair fit, making sure you wear your seatbelt. And I think these are very important sort of day-to-day common sense things that should be addressed by the team and by the family in trying to prevent a fracture. Next slide, please. We, however, do know that in children with DMD and those who are treated with steroids, spine compression fractures or vertebral fractures are actually extremely common. If we look at studies, including our previous paper, which looked at spine compression fracture that present with significant and very severe back pain, probably about 10 to 20% will have this spine compression fracture. And I'm sure some of your young person with DMD will have experienced this. And this can cause extremely significant pain, which may need very strong painkillers. However, we know that spine compression fractures can also be present or can be seen without pain or with very minimal sort of chronic back pain. But when these fractures are present, it does suggest that the bones are very fragile or very brittle, and that treatment to try to protect bones is necessary. And as a lot of you will know, that over the last couple of years, there's a move by from the recommendations of the International Standards of Care that routine and regular special X-rays of the back should be performed to screen for these fractures and for treatment to be commenced if these fractures are identified. Next slide, please. So these are some pictures of these lateral spine images of boys with DMD, and these are taken from side on, and you can see that the vertebra or the backbones are usually, if they're healthy, they are rectangular in shape. You can see that in the middle is a boy with some mild compression fractures where they're not as rectangular. But then you can also see on the far right is an X-ray or a picture of a boy who've got multiple fairly advanced fractures affecting most of the backbones, as you can quite clearly see that they're not rectangular in shape, but sort of quite squished. Next slide, please. So some of you will say that are worried that maybe your son have not had an X-ray to look at spine compression fractures in accordance with the standards of care. There is a move towards using some newer DEXA or bone density machines, which can allow good enough quality pictures to be able to diagnose or exclude spine compression fracture. And the advantage of that is that doing a test rather than just moving on from the DEXA machine to the X-ray machine, from one test you can actually get an estimate of the young person's bone density, but also be able to study to see if there are any compression fractures. The DEXA scan also is associated with a much lower radiation dose, although the X-ray dose is not particularly very high. So it may be that, and we're aware that quite a lot of centres in the UK do have access to these modern DEXA machines, which allows evaluation of the lateral spine to look at vertebral fractures. Next slide, please. I thought what's quite often asked as well is that what is a DEXA and bone density scan and how is it performed? And I think some families are keen to find out, particularly if you've not had it before. In the UK, generally, most bone density scans performed in the pediatric hospital will get two views, a total body bone density scan, which measures the bone density in the whole body. The scan itself takes approximately about 7 minutes. And then that's a position for the spine bone density, which takes probably about 2 to 3 minutes. And in centres where you have a DEXA machine, which allows the lateral vertebral fracture assessment, that's a position that the young person needs to be. And the scan itself takes about 2 minutes. But of course, generally, most of the DEXA appointments is within about 30 minutes because there will be some movement around and repositioning. Next slide, please. So what are the UK recommendations of bone monitoring? We know that vitamin D deficiency is very common in most parts of the UK. So we recommend that all boys with DMD should receive some kind of a vitamin D supplementation. We also recommend that a blood test should be done once a year to ensure that vitamin level is sufficient to at least 50 nanomoles per litre. To simplify things, as Cathy mentioned, we've recommended that all boys with DMD should have a lateral imaging of the back to screen for spine compression fracture. There may be some specific incidents where your clinician may actually not do it or not do it as regularly. In boys with very severe scoliosis, for instance, the images can often be challenging to interpret. In some boys where there is already metal in the spine because of scoliosis, your doctor may decide to do it less frequently or at least once just to check to see if there's spine compression fractures. But in general, our recommendation is that it's imaging of the back, the screen for compression fracture once a year to simplify things and for doctors in the team to be able to remember it easily. We also recommend that a boy should have a DEXA scan to measure for bone density once a year. DEXA scans can only be done in a boy aged 5 years and above because they're good normative data from that age. So it's not particularly that useful in a younger child. But if you are in a center where you do not have easy access to a DEXA scan, what is recommended is that your team should prioritize the lateral back X-ray to screen for compression fractures rather than just worrying about DEXA scan. Next slide, please. So once there is evidence of compression fracture on these X-rays, whether there is back pain or without back pain, or if there is a long bone fracture, particularly with very minimal injury, so just from standing or just from walking, a referral to an endocrinologist or a bone specialist to discuss the use of bone protective medicines or bisphosphonate infusions, which some of you will be familiar with, is recommended. Bisphosphonate infusions obviously have its risk and its benefit, and it will be useful for you to be referred to a specialist to discuss that. Important also in terms of talking about risk and some of the side effects of bisphosphonate infusion is that sometimes, particularly with first infusion, boys can become unwell, and the stress dosing of steroids, which Talat mentioned earlier, is recommended, especially for first dosing of bisphosphonate infusion. So hopefully we've presented you with some clarity of the recommendations that should be performed as part of monitoring of boys with DMD. So thank you very much.
Thank you so much, Jarod. That was brilliant. So now we're going to hand over to Dr. Claire Wood, who's going to talk about puberty.
Thanks for inviting me to the webinar this afternoon. So I'm a clinical lecturer in Newcastle, and for the last few years I've been working closely with the John Walton Muscular Dystrophy Research Centre. Next slide, please. So I'm going to talk about puberty today, and in healthy boys we would expect a boy to go through puberty between the ages of about 11 and 12, but unfortunately in steroid treated Duchenne boys we tend to see marked pubertal delay, and sometimes they don't go through puberty at all. We know, as Jarod's also just said, that puberty is essential for the development of muscle mass and also bone mineral content. Can you click again? I think the pictures should come up in a second. And again. And again, please. That's perfect. And you can see on the graph on the bottom left here, where the red circle is, there's a doubling of bone mass in boys between the ages of sort of 10 and 20. And that is instigated by testosterone and by puberty. And so obviously if a boy doesn't go through puberty, he's not going to get that increase in bone mass. It's also very important, the timing of puberty, because as we know, a lot of boys tend to fracture around this age, and about half of those can lose their ability to walk after a fracture. So obviously if we can maximize muscle strength and peak bone density, then potentially we can keep these boys ambulant for longer. And on the right here, this is just an example of one of the boys we've treated in Newcastle. And you can see that at the age of 8 along the horizontal axis, their Z score, so their sort of bone mineral density from DEXA compared to the population is above 0. So actually that's okay when they start steroids. And then you can see the gradual decline by the age of 10, and then the sharp drop off by the age of 12. And that's because we would expect in the healthy population boys to go through puberty and to gain all this extra bone mass. But unfortunately, that's not happening if they're treated with steroids and we don't give them any extra help. And then the sharp drop off again that you can see here in this boy at about the age of 13 is when he becomes wheelchair bound. And so it's really important in this population to think about how we can maximize their bone and their muscle content. There can also, and as Vicky alluded to earlier, be important psychological components to delayed puberty with respect to height and looking older, looking different from their peers. Next slide, please. And we know that testosterone has a huge number of benefits. In order to go through natural puberty, we need levels of testosterone of 30 times higher than childhood. And this increase in levels, this surge at puberty, improves growth, it improves mood, confidence, obviously the standard pubertal characteristics that we know, but it also increases, oh, sorry, can you just go back again? Sorry, red cell production, so helping oxygen transport around the blood, the maintenance of bone density, and also this improvement in lean muscle mass and strength and the changing in body shape as well. Your next slide, please. So we've just actually published the results just on over the weekend of a study that we've been carrying out in Newcastle. And this was a clinical trial looking at giving testosterone in boys with Duchenne. And you can see here on the left, the inclusion criteria. So it was fairly straightforward and a very practical study. It was boys with Duchenne who were between 12 and 17, who hadn't gone through puberty yet, were receiving the usual care for DMD and were able to participate in the study. So they could sit up in their wheelchair and they had stable respiratory function. And what we did was, for all of the 15 boys, we gave them a standardized, gradually increasing dose of intramuscular Sustanon, which is an injection of testosterone. And we started off with a very low level, which you would normally get in early puberty anyway, a sort of priming dose. And then we gradually increased the dose to a full adult level by the end of the 2 years. And we measured lots and lots of components. We interviewed the participants. We asked them to fill in treatment satisfaction and quality of life questionnaires. We examined changes in physique, bone health, muscle pathology, which we looked at using MRI, and muscle function over the study period. And the study has very pleasingly shown us that testosterone was safe, it was well tolerated, and importantly, it was associated with high satisfaction scores in both the boys and their parents. And you can see here, this is just one example of a graph from the study. And this shows here the results from the main outcome of the study, which was the treatment satisfaction questionnaire. And along the bottom here, there are different groups. So there's the overall treatment satisfaction, and then symptom relief, time to work, ease of use, easy planning, and global satisfaction. And hopefully you can see here that all the scores, when they were rounded up to the nearest whole number, were between sort of 5 or 6 and 7. And 7 means basically highly satisfied. And so overall, the general consensus was that the population of boys that we looked at anyway, they wanted testosterone. So next slide. And as we'd hoped, by the end of the 2-year period, all the boys that we studied were clinically in late puberty. So physically, and also from their blood tests, it showed that they were in late puberty. And the graph on the left here just shows the testicular volume. And the orchidometer on the right here is just a reminder. This is a guide that we use to try and evaluate testicular volume. And it's not easy in this population, as I'm sure if you've got children yourselves who've been examined, it can often be very difficult, particularly if boys are in a wheelchair, to actually be able to evaluate this. But what we found is that at the beginning, when we first started testosterone, all the boys were prepubertal. So basically on the orchidometer, they all had testicular volumes of less than 4 mils. And then by the end of the 2 years, their volumes remained low, as we would expect, because we were giving them testosterone. But about 6 months or to 9 months after we stopped the testosterone injections, hopefully you can see here the green triangles on the graph, their testicular volume started to increase. And this suggests that once the testosterone injections were stopped, the boys themselves started to produce their own testosterone. And this is very reassuring, so that by 6 months after the injections finished, the mean testicular volume was about 8 mils. And if you can see on the orchidometer there, that's suggesting sort of mid-puberty. And the boys that we've continued to follow up, these testes have continued to grow, suggesting an ongoing testosterone production. Next slide, please. And one of the big concerns that these boys have, that we hear in clinic a lot, is about their short stature and how they look different from their peers. And we picked up in the interviews and in the treatment satisfaction that one of the main improvements the boys themselves felt was they looked more like their peers. You know, they were starting to need to shave, they looked older. But also, hopefully this graph here on the left can allay some fears, actually, because there's 2 ways of looking at it. The boys themselves want to be taller, but as Vicky said, it can become difficult in this population when they need a little bit more help with their self-care if they're, you know, too big. And there is some suggestion that boys who are on the smaller side do slightly better. So I just wanted to show this really for reassurance that there was some height gain. You know, we found that there was some increase in height, but if you can see on the graph, nowhere near where we would expect them to be in terms of their target height if you compare mum and dad's height. But you can see that in the boys who are a little bit smaller to start with, they were the ones that gained a little bit more height, but we're only talking 8 centimeters average height gain during the study. So I would hope that that's a very manageable height gain, but can make a big difference to the self-confidence in these boys. And I'm not going to go into all the sort of science in the study, but I just wanted to highlight this quite exciting finding for me anyway, which was from the muscle MRI. And essentially we found that the healthy muscle bulk in the arms and legs on MRI increased during the study. And the black and the turquoise bars are the levels before the 2 years of testosterone. And the CSA just stands for the surface area, so the cross-sectional surface area of the muscle. And as you would expect, because these boys have grown a little bit, that the overall area of the muscle has grown as well, which is great. But what we found, which is a little bit more exciting, is the purple bar here shows that the contractile surface area has also increased. So basically the healthy muscle that hasn't been replaced by fat or fibrosis also increased here. So not only are these boys developing stronger bones and they're looking older, they're developing a little bit of height, but also we seem to have shown that they're actually developing an increase in healthy muscle. And we obviously haven't got a control group in this to compare it directly to, but lots of the natural history data suggests that this isn't the case in this age group normally in Duchenne. So this was quite exciting. And we also found that there were reduced levels of muscle inflammation in the MRI scans as well, suggesting that testosterone perhaps is slowing down the progression of the disease, as well as the obvious effects on puberty itself. Next slide, please. So the standards of care, as we've been obviously discussing today, have been sort of modified slightly here just to make it nice and simple. But essentially what we're hoping is that a conversation will happen where the likelihood of pubertal delay and the need for testosterone in these boys is introduced into the muscle clinic at around sort of 10, 11 years old, with the idea being that an assessment of puberty will follow at around this time, and ideally in all boys once they get to the age of 12. And as I've said, it can be difficult to assess these boys. So that may require a referral to endocrine to do that. It really depends on the muscle clinic themselves and whether they feel comfortable assessing puberty. What we would hope is that all boys who have no signs of puberty are referred to an endocrine clinic before the age of 14, because we would hope that we can start one of these testosterone regimens on all boys by the age of 14. Thank you.
Thank you.
Claire. Thank you to all our speakers. We've had quite a few questions come in, so I'm going to go from the top. So they're slightly jumping around in terms of subject area. But the first question, do you recommend prophylactic bisphosphonate infusions? And which do you think is more effective, oral or infusions, please?
So Emily, shall I take this question?
We'll start off, Jarod. Yes.
Right, so the standards of care have already changed significantly since the first version of the standards of care in 2010, in that lots of fractures or very painful vertebral fractures is the threshold for us to start bisphosphonate infusions. So this current standards of care recommends that if you've got one long bone fracture or even some fractures in the back without any back pain, that bisphosphonate infusions can be started. Sure, it probably makes sense to consider the use of preventative bisphosphonate, but we simply don't have enough of the data, and it may be that this is the area that we'll be moving to in the near future. But bisphosphonate infusions do have some side effects, and I think that's and I'm sure some of you or families who have used bisphosphonate infusions will allude to that, and that's something to just consider. Oral bisphosphonates are available, but oral bisphosphonates are not particularly very potent, particularly in children. It's also not very well absorbed and causes indigestion. And we do know that, that some boys with Duchenne's do actually have gastritis or gastric irritation as a result of steroids. So generally in this current sort of paradigm of treatment where we find fractures suggesting very weak bones, we go with strong medicines of infusions to treat the osteoporosis. But prophylactic bisphosphonate, not quite there yet, but maybe we will move there with some available evidence. Emily, I think you're muted.
Let me just ask a follow-up question. Are bisphosphonates as effective in all bone, i.e. in the femur, as much as in the spine?
So bone protective medicines as a whole, generally is much better in the spine. And I think what we do see is that if you give bisphosphonate infusions in lots of conditions with osteoporosis or in Duchenne, the vertebral fractures, the fracture in the backbone do seem to stabilize. it's perhaps slightly less potent on the long bones. And I guess in DMD, when you actually have the whole fall likelihood, I'm not quite sure that just using bisphosphonate alone will completely prevent long bone fractures, and we still see some boys who are on bisphosphonate infusions who still fracture their long bones either from walking or falling from wheelchair.
Okay, thanks, Jarod. The next question from Joanna Del Mar. What age do you start lateral spine imaging?
So the lateral spine imaging is, the recommendation is that you start around the time of just before starting steroids. Most boys are probably diagnosed around the age of 4 to 5, basically. So there's no lower threshold. It can be done in much younger children as well. But I think most boys will around about the time when you actually start steroids, or if you're already on steroids from whatever age, basically.
Thanks, Jarod. A question now for Claire from Kerry Rosenfeld. Can testosterone injections help improve bone mass?
Yes, so I mean, I think certainly in our clinic, that is our real main go-to. You know, when we've got a boy who's around 11 or 12 and their bone density is on the low side, we would encourage them to start testosterone as soon as possible, with the idea being that, yes, it should build up the bone density. In the testosterone study, we didn't have enough boys to categorically answer that question, but we did show that the bone density on the DEXA was stable. And obviously at the age that we were looking at these boys, you know, a couple of them went off their feet and they, you know, deteriorated. And despite that, their bone density remained stable during it. And some of them, actually their bone density did increase, yes. So I'd be very confident. You know, we know in the healthy population that testosterone is one of the best agents for the bone mass accrual. And you can see on those graphs, you know, that doubling of bone mass. So yes, I mean, I know we've got steroids to consider at the same time, but the likelihood is here that testosterone will certainly not do any harm to bone density and is likely to help it.
Okay, and Claire, can I just ask a follow-up question? On the slide you showed about how testosterone increased healthy muscle on the MRI, you saw that. Was that reflected in any functional tests that you did?
So again, as I say, because it was just a pragmatic study using our local population, it wasn't powered to look at the functional outcomes in terms of physiotherapy. But what we did find is that we didn't get the deterioration in muscle function that you would expect in this group of boys. So, you know, normally when you're following up in the natural history, a group of boys who are between the ages of sort of 12 and 15 for a couple of years, you would expect their North Star and their upper limb function to deteriorate, and we didn't see that. So although we haven't necessarily seen an improvement, and we did see an improvement in some of the boys individually in their North Star assessment, on the whole, again, this was a picture of a maintenance of their muscle function rather than the expected deterioration we would see. And as I'm sure you know, Emily, what we're hoping to take this forward and do some more studies now to look at using testosterone, you know, possibly a little earlier, and trying to look at the effects on this exciting sort of finding in muscle in more detail.
Okay, thank you, Claire. A question from Richard. Many boys find DEXA scans uncomfortable, and some ask why it should be done annually if we are only going to treat with bisphosphonates if they have fracture or back pain. So if we are employing all preventative and supportive measures, including vitamin D and calcium, what is the value of documenting a low BMD with an annual DEXA? Jarod, you're on mute.
So thanks for the question. So yes, for sure. So a single DEXA is not particularly very useful at all, but the idea, which was actually detailed in the standards of care, is looking at trends of DEXA bone density as standard deviation score, or Z scores. And what that also tells you is that if there's actually a drop of more than 0.5 standard deviation, that you ought to prompt looking into fracture history and also spine imaging. But obviously, if you do find that you have limitations to accessing a DEXA scan, and there are some of my boys who just do not like having a DEXA scan, you prioritize spine imaging. So I think it's useful as an adjunct, but there are some circumstances where it can't be performed for a whole host of reasons.
Okay, I wanted to jump in and just ask Talat a question about adrenal failure. How, I mean, from your slide, you know, I think we realise now how dangerous it is potentially, but how quickly can boys slide into that dangerous phase?
It's a really broad question. I think that a lot of it depends on the individual, because we've all got our own susceptibility to steroids. Some of it will depend on how much, what dose of steroid you've got. If you're on high dose steroid already, then I suspect you'll probably be okay, because I think historically boys with DMD haven't been given steroid stress dosing plans. Some of it will depend on the severity of the illness. I think the most important thing to remember is that if they're unwell, they need steroids, and even if they're being unwell, even if they're having an illness and vomiting and not eating anything, then the most dangerous thing to do is not to have the steroids. I think I've probably sort of talked around your question rather than give you an absolute answer.
I mean, so I suppose the question is, you know, as a parent, could it happen overnight or within a matter of hours? Or are the symptoms, do they give you a bit more time to be able to assess what's actually going on?
So the easier one to answer is, so with a fracture, it may be happening straight away. And otherwise, if you've got an illness that's working on you in the background, then it may take hours. And if it's a milder illness, it'll just linger on for quite a number of hours into overnight and the next day.
Okay, thank you, Talat. Another question from Miguel. Would you recommend calcium supplements together with vitamin D as part of the standards of care? I think that's for you, Jarod.
I thought people would have enough of bone questions for me since I crop up all the time. So, so calcium supplementation. Well, so firstly, calcium's not very nice to take anyway. So, as part of bisphosphonate infusions, most boys in most centres will be asked to take about a week of calcium, and most boys don't take the whole week of that. So, what we would recommend is that to ensure that the young person takes enough of calcium through diet first. And I think in the Western diet, this is generally kind of quite easy, but in some people you might need calcium supplementation, but I certainly haven't needed to give anyone regular ongoing calcium supplementation. So that's probably not routinely needed.
Will the standards of care make a recommendation about that though, so that everyone will follow the same regime?
So I guess, no, there's no need for routine calcium supplementation in terms of medicines, but there should be an assessment of, the clinic should talk to you about having enough calcium in the diet.
Okay, thank you, Jarod. I've got another question on testosterone. Is there an upper age cutoff for starting testosterone treatment, Claire?
No, there isn't. And certainly when we first started using testosterone in Newcastle, kind of back in the, I think it was probably early 2000s now, we were routinely finding boys in their 20s, you know, who hadn't gone through puberty, and we were starting them on the regimen for a couple of years. So no, there's no upper limit, but what we have found is that the boys who were started on it younger seem to do very well and fairly quickly go through puberty. And so in terms of, we know that it has psychological advantages, and obviously because of the advantages on bone and possibly now also on their muscle function, I think we're hoping that we could start all our local population by the time they're sort of 12, you know, to maximize the chances of their bone development, and all, you know, also to try and prevent these boys from being different from their peers. And that's what, you know, I would say. But there is no upper limit. And what we don't know either now is whether we'll need to continue supplementing these boys as they become, you know, young adults. And so there's no problem with starting somebody on a testosterone supplement even after they've gone through puberty a few years later. If we then find their levels are low, there'll be no harm in, you know, restarting testosterone at that stage. You're on mute, sorry.
Just another follow-on question on that. Would there be any other contraindications to starting testosterone?
No, I mean, not really. It's very, very safe. It's been used for years. It's obviously a natural hormone that we, find in the body. And I mean, obviously, there are precautions that we need to look out for, and we would monitor by seeing patients on a sort of 6-monthly basis, just to check that the puberty is not going too fast, for example. But no, there's no specific contraindications really.
Thank you. This is a question from Becky. Are testosterone and bisphosphonate infusions more effective on boys who are on an intermittent steroid regime?
I don't know whether Jarod wants to answer this one, or
Do you want to go first, Claire?
So in terms of the intermittent regimens, and we don't have a lot of the boys up in the northeast on these regimens, but I guess it is possible that those boys may go into puberty themselves and have some natural testosterone going around. So possibly we would need to only sort of prime their bodies, and then we may find that they then start to go into puberty themselves, if you don't have the steroid on board all the time. It would be just a question of starting off and seeing how these boys respond. Within the study where we were giving exactly the same dose to all 15 boys, we did find that after 18 months, there were a couple of the boys who were happy with their pubertal development at that point, and we didn't need to carry on for the full 2 years. And I guess if I was to sort of think about it logically, if a boy was on an intermittent regimen, I would expect him perhaps only to need 18 months, or, not to go up to that final adult dose, that their bodies may kick in a little earlier, because the axis that Talat was talking about, the hormone production isn't necessarily quite as suppressed in those boys. So maybe we would find that we would need testosterone, for slightly less period of time.
Thank you, Claire. Jarod, I'm not sure if you're there.
Yep. So I guess the only thing to mention is that I think if you're on an intermittent steroid regimen, there's nice data from the Birmingham group, which shows that fracture is less frequent compared to those on the daily regimen. We've actually got data to show that similarly, we have not got many patients on the intermittent regimen anymore. But actually, if you're on the intermittent regimen, you're likely to actually have puberty that starts. I have a small number of patients who's a bit slow in completing puberty. So I can't really comment on whether the medicines are likely to be more effective, but I think those problems are less frequent.
Thank you, Jarod. Claire, there's a question from Kerry. I think you may have covered this in one of your previous answers, but how long should testosterone be taken for?
So obviously, different centres will have their own established practice, but we would say over the course of a couple of years, what we want to do ultimately is to mimic normal puberty. And if you think of a healthy teenage boy, they'll start puberty round about 11.5-ish. And they develop and then they grow fairly late on in that. So after a couple of years. So what we're trying to do is to take these boys through as natural a process as we can. And obviously there are problems that you can get if you increase the testosterone levels too quickly. They can get nasty mood swings, which nobody wants. You can get a bit spotty. There can be other complications. So ideally, we would just want to take them through at a nice, gentle pace that makes them feel comfortable and gives everybody in them around, a chance to come to terms with it psychologically as well, rather than doing it too quickly.
Thank you, Claire. Talat, a question for you from Vicky. My son is 16 years and 9 months old. He started steroids at 3 and stopped at 12. Do we still need to be concerned about adrenal failure if he gets unwell? He's also been taking Sustanon injections every month for a year now.
Yeah. Hi, Vicky. I presume if he's been off steroids, his adrenal axis has recovered. Usually after a period of adrenal suppression, we would reduce the doses of prednisolone or steroids steadily until they're off it. And then at some point, some people may just wean them off slowly and stop, and others, they might do some blood tests to check if their adrenal axis has recovered. But I suspect if he's been off it now for 3 years, he's probably fine, and they're producing normal amounts of cortisol. And especially if he's generally well and stays well during illnesses, I would be quite reassured.
Thank you, Talat. And a question from Becky. What should we do because as you know, patients are on deflazacort or prednisolone. One question from Becky: what should we do with deflazacort on the stress dose for illness? Should we still inject hydrocortisone?
So irrespective of which steroids you're on, the emergency medication is just hydrocortisone by injection. There's no other steroid formulation that we would give by injection. So if they're on deflazacort or prednisolone on alternate days, then the default emergency treatment is the injection. I think the only difference is what to do about the oral steroids when you're unwell, whether when you're on one regimen or the other. I think that's quite a big question, and I believe there's other webinars planned to get feedback from families on whether they would prefer to have hydrocortisone to take orally as well, or for everybody, or to have prednisolone for those that are on prednisolone. The important thing to remember is as long as you have more steroids of either hydrocortisone or pred and have an emergency hydrocortisone injection, that will keep you safe.
Thank you very much, Talat. So I think we've answered quite a few questions there. So thank you so much for answering and for those really fascinating and useful presentations. I'm just going to throw back to Alex and Cathy now, because obviously there's a huge amount of information to digest in this webinar, Alex, but how do patients go about making sure that they have this information to hand, they can take it to their clinics and make sure that their sons are being given the right care at the right time?
Thanks, Emily. So we are uploading all this webinar to the DMD Care UK website, which the link's on the slide. We're also, we've produced with the working group some leaflets, one on puberty and testosterone treatment, and one on adrenal insufficiency, that are available to download online, or they can be ordered via the website, and also the wristbands can be ordered on the website. But we are disseminating this information to the whole of the North Star network, so it is being made available to the community, because I think one thing that we're always conscious of is sometimes these guidelines are published, and then as a patient you go in to see your clinician and perhaps they've not been made aware of it. So a big thing that me and Cathy are trying to do is to work with the North Star sites to ensure that they've got all this information. I don't know if Cathy wants to add any final comments about that.
No, I just support what you've said, Alex, and also to bear in mind that that this working group that has made such excellent progress so far, and already the work certainly doesn't stop here. So continuing to work together as a group to address some of the questions that have been raised, to look at some additional research questions that are required, to educate the community, both clinical and the patient community, and to help support the implementation of these standards of care, because I think, as Alex and I both said, there's no point in having new higher standards if they're not implemented. So the work continues, and do get in touch with us if you have any questions or want to be involved.
Yeah, and you can email support@duchenneuk.org if you have any other questions that have come up following today's webinar. I just want to say a huge thank you to all of the panelists today. I thought you were all excellent. You know, Dr. Jarod Wong, you have just been amazing throughout this whole project. And, you know, we definitely could not have got this set up without you. So a big thank you. And Talat, I thought your presentation was really interesting, because it's something as parents, perhaps I'm guilty of not really understanding when we should give these stress doses. So I know that discussions are ongoing as well about hosting maybe some online workshops about that to give people more information. And finally, to Claire, I'm very excited by the outcomes of your study and how we can look at using that data to improve care. So a big thank you from everyone at Duchenne UK for taking part in the webinar today. Thank you.
Thank you very much.